Good afternoon, everyone. So today I'm Dr. Amitha N. I'm working as a fertility consultant at Electronic City, Motherhood. So we have just celebrated the World IVF Day, and on this occasion, here is a webinar on if IVF failed, what next. So I'm sure a lot of people are there, a lot of couples out there who've had a failed IVF cycle and wondering what next to be done, or probably a lot of people would have got advices as well as to either repeat the cycle, go for donor cycle, or do some required advanced tests and then proceed further. Now, on what basis do we decide all this, and who are the couple who are capable for the different kind of modalities that are available is what I'm going to discuss today. Now, IVF failed. Why does an IVF fail? Usually, IVF fails for either female factors or because of male factors, or sometimes it is combined factor as well. Now, coming to female factor, the most common thing that we are facing in the present generation is the advanced maternal age. Now, women more than 35 years of age to 37 years of age fall in this gray zone, and women more than 37 years of age in Southeast Asian region have high risk of anomalies, that is chromosomal anomalies in the embryos, because of which the implantation may not happen, or even if the implantation happens, there is risk of miscarriages or anomalous fetuses in the during the pregnancy. Now, how do we deal with this? Usually, when it comes to advanced maternal or paternal age, it is a known thing that there is a lot of non-disjunction or chromosomal defects or breaks in the chromosomes that can happen with advanced age. Now, when we use such gametes for ICSI and we get embryos, most of them have abnormal embryos, that is aneuploidies. Now, how do we treat this? So basically, we do a test called pre-genetic implantation screening, where we screen the embryos for presence of any aneuploidies, that is chromosomal abnormalities. And the embryos which don't have the abnormalities are called euploid embryos. And these are the ones which we will use for embryo transfer. Now, say suppose we have a couple who are 39 years of age or 40 years of age, they've undergone an IVF cycle and they have failed. And for them, when they come to us, the first thing we would tell is if everything else was normal, first go for another cycle of egg pickup, create embryos, and once the embryos reach the blastocyst stage, then biopsy these embryos to look for any chromosomal abnormalities. And if there is no abnormalities and these are euploid embryos, go ahead with the transfer. But if it is an abnormal embryos, then it is an indication that because of advanced maternal age, they are having repeated abnormal embryos, and that's when we suggest either to change the gametes or to further go for another cycle. This is about the advanced maternal age. Now, the second most common thing that we see for failed IVF is if anything is related to the endometrium. Now, when I say endometrium, it has a lot of causes for a failed IVF cycle. The most commonest being if there is presence of any polyps, or the endometrium has any fluid present during the embryo transfer, or it is not fitting in the receptive window. These are the most common things. Now, how do we tackle it? As soon as we have a one failed IVF or failed embryo transfer, the first thing we do is a basic hysteroscopy test if it is not done earlier. Now, what is it? It is basically a camera that we insert inside the uterine cavity from the vaginal route and look for the abnormalities in the uterine cavity. If there is any presence of abnormal endometrial tissue or polyps or any other growth, we first try to remove them and see if the cavity is normal. There are a lot of women, because of the hormones that we give, they start developing multiple polyps or irregular growth of endometrium. So in such women, what happens when we place an embryo, because of the fragility, the embryo doesn't get implanted. So what we do during an hysteroscope, as soon as we diagnose, we take off those, we resect the polyps or do a minimal scratching, or we do a proper DNC to get rid of all those polyps or abnormal endometrial tissue growth, even it out, and then probably give a cycle of OCs or OC pills or other medications like GnRH agonists, and then bring it to normalcy, and then go for embryo transfer. This is a first most common cause when it comes to endometrium. Now, we have also seen a lot of women who don't fit into the endometrial receptivity. Now, what is endometrial receptivity? We call it as the ERA test. Now, what is it and how do we go about? Now, usually ERA test is done for people women who have had multiple embryo transfer failures. Now, how do we go about it? We prepare the lady as we prepare for the embryo transfer, and instead of putting the embryo, we take the endometrial tissue and find out if it is a right window to do the embryo transfer. Now, what happens at the molecular level? During the embryo transfer, the endometrium should have developed finger-like projections called pinepoids. Only if this is developed and we place an embryo, the endometrium engulfs the embryo and implantation happens. Suppose if the spinopoids are not developed, or developed and it has already crossed that period, we call it as either pre-receptive stage or post-receptive stage, and we place the embryo, the implantation will not happen. So first thing we need to understand is if the women FET has happened at the right window of implantation. So this is another test where we try to find out the endometrial implantation and then proceed further. I was also talking about the presence of fluid in the endometrial cavity. Now, this also forms one of the major reasons why FET fails. Now, what is this? Sometimes because of excessive hormones or because of any infection, the fluid can enter the endometrial cavity and remain as a thin film of fluid in the cavity. Now, when we place a embryo inside such a cavity, and if we have missed it during the scans, the embryo will not get implanted. Instead, it will get washed off. So, how do we tackle this? As I told previously, we can do a hysteroscope to find out if there's any infection, or if there's any growth that is secreting, or if it is clear just the hormone excess that is releasing fluid inside the endometrial cavity. So if it is because of any infection, either in the endometrium or because of the fallopian tubes or because of the PID, we call it, in the pelvis, then we'll have to tackle it in the same scenario. So if it is in the cavity, we can wash off the endometrium. If required, do a endo scratch and then give them a course of antibiotic. Test the fluid for any presence of TB or any pelvic infections. And if at all if it is coming from the tubes, do a laparoscopy as well. Find out if the tubes are affected, if there is any fluid in the tubes, we call it as hydrosalpinx, or if there is any infection in the pelvis around the uterus. So if there's any of these things, suppose if there is a hydrosalpinx, we do a clipping and disconnect the tubes from the endometrial cavity so that the fluid doesn't enter inside. Suppose it is PID, look for presence of any chlamydial infection or TB infection or any other PID and treat it accordingly. So we give a course of antibiotics and then prepare her and do again prepare her with the HRT to look for presence of fluid again. And if there is no fluid, you can go ahead with the embryo transfer. Now, when it comes to male factor, the most commonest cause, as we all know, is a very poor quality sperms. Now, what happens when we say very poor quality sperms? What is the cause? As we all know, there's a DNA in the sperms which gets fragmented, which is leading to abnormal embryo formation. And if such kind of embryos are transferred, again, there is no implantation or there can be implantation failure. Now, how do we tackle this? We can give a course of multivitamins. There's coenzyme Qs and all that we give for about 3 to 6 months. See if there is any improvement. Second, we give hormones to increase the number and motility and also the overall growth, improve their lifestyle. Then give good diet, and then lifestyle also includes the exercise, avoid smoking, alcohol, and also we can do TISA or PISA. These are surgical procedures that are done so that we will be directly able to pick up the sperms from the testes instead of collecting it from the ejaculatory duct. Now, so many times when there is external stress or there is varicocele or the person is into heavy weights, if he's into gymming and all, then because of the presence of heat the sperms present in the ejaculatory duct can go in for damage. So to avoid this, what we do, we take the sperms directly from the testis and then use those sperms for the ICSI procedure so that the risk of abnormal embryo formation is avoided. And such sperms can be used, and also we can also do PGS testing to see if there is any abnormality in the embryo, and then accordingly just transfer the embryos that are absolutely normal. So this is about the male factor and the female factor and basic things that we do. Now, when a woman or a couple comes with multiple IVF failure, first important thing remains is the diagnosis, like I have already discussed. Second thing comes preparing up. Now, when do we go for the second cycle? How early can we start? And what are the basic tests that we again do to prepare up? So usually we generally give a gap of 2 to 3 months before starting another IVF cycle or FET cycle. And then we give them the multivitamins that is required, like the multivitamin D, B, E, A, and also change their lifestyle in terms of, to improve the circulation, ask them to do cardio exercises, inculcate yoga, pranayam in their regular daily lifestyle, daily routine, and follow a proper diet pattern that will help them to improve the circulation and also the improve the circulation to the uterus and to the ovaries so that we get better quality gametes and the better quality endometrium in women. So once we do this for 2 to 3 months with medications, that's when we again call the patient and then decide on the treatment. Now, in treatment, as I told, the first thing is a lifestyle change. Second thing is the diagnosis and the routine treatment that we advise, like the hysterolaparoscopy or ERA test. In few women with very low AMH or somebody who has good egg count but they're not able to form good embryos, we do something called intra-ovarian PRP or endometrial subendometrial PRP. Now, what is this? Intra-ovarian or subendometrial PRP is to improve the quality of the gametes or to improve the quality of the endometrial lining that is being formed. So basically, we take the blood from the patient and we separate the platelets and plasma, and the plasma rich fibrin or that content is taken and we inject it directly into the ovaries or in the subendometrial region. Now, what happens when we do this is this neovascularization that happens, and because of this neovascularization, we get better quality eggs or better endometrium. Now, as I told, if there are somebody who have had poor AMH or they are not able to form good embryos, this will benefit them. So we do one cycle before the stimulation, I mean the second IVF cycle, and once the patient is ready with PRP, intra-ovarian or subendometrial, that's when we stimulate her again, collect the eggs, create embryos, and then go in for transfer. This is the third thing. And fourth thing, as I discussed, we can go in for pre-genetic testing. So in pre-genetic testing, again, we do the embryo formation, that is get good blastocysts. And once we get the good blastocysts, biopsy them, and then the biopsied embryos can be transferred into the uterus. This is a basic thing that we follow. And any mode of any couple who come for second IVF needs to be thoroughly evaluated as to what was the reason for their first IVF failure. And the last option would always remain change of gametes, that is either go for donor eggs or donor sperms or go for donor embryo. Suppose we have a couple who have very poor AMH and or they are having abnormal embryos on PGS, then the answer would be to go for change the gametes and get better quality embryos and transfer them to the uterus. Suppose the last option is if a woman is having very poor endometrial cavity because of presence of fibroids or the endometrium, very thin endometrium, it's not growing, or she has very severe endometriosis, adenomyosis, or because of previous surgeries, the endometrium is completely, not in good, we are not able to get triple line. In such cases, the only option will remain to go for surrogacy. So whatever the condition is, the most important thing before going for a second IVF cycle is evaluation, proper diagnosis, and then treat accordingly. So is there any questions?
Hi, ma'am. We'll take the questions on the live session on YouTube. So if there's any, we'll direct it to you and you can answer them.
Okay.
Thank you so much, ma'am. Thank you for your valuable time.
Thank you.